This is our last session, session 4. We have 2 presenters. The first will be Dr. Okeke, so I'll turn it over to her to cover her section, and then she'll turn it over to Ashley.
Yeah, thank you, Angelica. And I'm back again. So in this session, we have 2 parts. In the first session, we will complete the phase 3 of the patient's journey, and the second part, we'll discuss social determinants and patient engagement. So for the first part of this session, I hope you take away from this session the understanding of the following concepts: episodic and transitional care management, the use of the CRISP ENS report and all the CRISP tools to risk stratify your high-risk patients, following up with them, and advanced care planning. So again, for those of you who downloaded the handout, you get to see the summary in there. And the following slide also is a quick summary of the key steps in the patient journey, the care team members who could be part of the process, and the technology and resources that you could use. So in the last session, Yaya already reviewed the longitudinal care management piece, or long-term care management. In contrast to long-term care management, you should also provide episodic care management to your patients who have had a recent discharge from the hospital ED, but there are other things that could require you to actually provide episodic care management for your patient, such as a life-changing event, a new diagnosis, a recent discharge from a SNF. So in this short-term care management, key things you should keep in mind is that, first of all, you have to have a way to identify these patients. Again, most of you already use the CRISP ENS alerts. I would say that's your first go-to data source. And then when you have that data, you should outreach your patients as soon as you can. In the MDPCP program, for those who have a recent hospital discharge, you have 2 business days to contact the patient, and for ED post-ED visits, 7 business days. So keep that in mind as you plan your workflow. Other things that you can do at this time that's helpful is the medication reconciliation, and this folds into making sure that the patient also has a scheduled PCP visit, preferably within 7 to 14 days post-discharge, and the PCP would complete the medication management for the patient and all other care needs at the time of the PCP visit. So continue to follow up and monitor your patient during that episode of care until they are transitioned. Please bear in mind that there is a balancing act that happens between the longitudinal care management and the episodic care management. I thought this was a good graphic to depict that movement. So because your patients, even though, for example, are already in long-term care management, they could have a recent hospitalization or ED visit that now qualifies as an episode. And on the other hand, you could have a patient who was previously stable, but after an episode, they will now require long-term care. So what we know to be true is that if we can provide long-term care management, we can reduce avoidable hospitalization and ED visits and the associated cost and pain, and which is the core of what the MDPCP program is really about. So in this next slide and the one after it, we'll be looking at practical workflows of how this can be all tied together. So short-term care and long-term care, as we said, is a balancing act that kind of happen concurrently. And this is also in your handout package for those of you who've downloaded it, so you can see it. And again, as Angelica mentioned, she would be sending that out to everyone who is here if you were not unable to download it. The first example in this slide is a simpler structure where you're looking at, on the left-hand side here, the care team roles that are identified. You have the PCP, the panel manager, the lead care manager, and the MA or support care manager. You should also appreciate the handoff from one care team member to the other. For example, the PCP can refer a patient directly right here. So these are the swim lanes, right? So the PCP right here can refer a patient to the lead care manager for longitudinal care management. And you can also have the panel manager, after triaging a patient, for example, that had an episode, either a recent ED visit or inpatient discharge, to the lead care manager. When the lead care manager gets that referral, they're supposed to outreach the patient, conduct an assessment, and then determine whether that patient should be receiving longitudinal care management, and then establish a care plan for that, and also make sure they also refer the patient to other care needs that they may have. For example, one very common one is for community health support to address their social needs. So right here, I think because we have a number of, would I say, care team roles that may cut across the practice, the CGO, the vendors, or whoever else, it's good to have a graphic, I guess, representation of what everybody does and understand what the handoffs are as you identify and come together as a care team to determine how best to support your patients. The second slide, as you see here, is a more complicated looking view or workflow, but that's only because you have more care team members involved in this instance. So again, you have to do what's best for your practice, but just so you know, it doesn't matter, the combination you or your staff mix, you can always come up with a workflow that provides a seamless handoff. And more importantly, you can improve it. So if you start delivering longitudinal care management in the way that they kind of all work hand in hand, and you observe that you're not performing as well as you need to, because you do have some requirements like being able to reach out to 75% of all your patients that had a recent ED visits within the time frame, 2 business days for inpatients or 7 business days for ED visits. You can, kind of, again, using your PDSA test this change and see how it works and understand what steps you can change up or what responsibilities you can move around with your care team. So here I will just briefly touch on this since it was discussed in the last session. Remember that now we are getting more and more creative with how we can engage our patients, especially because of the COVID-19 pandemic. But no matter what we do, we should also keep in mind that our patients having 24 access to us is very helpful to them and definitely for us as well. So some of us already offer things you can see here in the bottom, same day, next day appointments, after hour services, some weekend hours as well. So let's keep doing that. And we have just started, most of us have just started telemedicine. For some of us already have been doing that for a while. So let's keep getting creative with different ways that we can engage our patients to ensure that we have 24/7 access. Now we're going to talk about using data to plan care. You have to appreciate the wealth of information, and sometimes it may be daunting about all these tools that you have and how do I use them, how do I apply them. The good news is that at least the tools are there. So now it's up to you to identify what data is available through CRISP, your EMR, and this is critical so you can have an informed decision on how you develop your workflows and how you analyze if you're performing as you should. You should also track your ECQMs and by provider and see how you can effectively organize the care gaps closures and resources to support the primary care providers. So here is a summary of the steps you should take to get organized using data to plan care. So first of all, you need to identify the crucial measures and data types. There are many things you can measure, so you want to focus on the vital few. The data types include claims data. You see utilization and cost information. Using that data from your EMR, logs or spreadsheets you keep to track gap closures with ECQMs or your practice performance trends, depending on what your PD is saying, and also data from surveys for your patient satisfaction experience. Next, you should also develop a data collection process and data analytics platform using a spreadsheet or any other data analytics platform you have in the interim. And then you develop and review your performance over time. And we are lucky that we already have some of this work done by CRISP, so the reports you can use, but you can also fill in the blanks with the interim outcomes you may be tracking, like how well or how often are we calling our patients who have a recent ED visit or inpatient, who's tracking that? Are we meeting our goal, and what can we do to address those, or for your patients who are high risk, are they yet receiving LCM, longitudinal care management? And if they are, do they have a care plan in place? What can we do to make sure they have a care plan in place and things like that? So let's quickly review some of the applications available for you in the MDPCP program that you can find on the CRIS portal. So the ENS prompt, I need not to say much about this. A lot of you are already comfortable with this and know about it. So please pay attention to the information that's there. That folds into making sure that you have care alerts in place for your high-risk patients. And this is sort of a short description of critical information you want anyone who's going to be providing care for your patient to be aware of, because it kind of helps with patients' care delivery. Please, everyone should be already assigned a practice coach from the state. So please work with your practice coach if you need to get in contact with your CRIS representative to help you make sure you set this up. Also, in the MDPCP reports, you have the population summary overview, and you can see a number of things that you can review all at one time: the inpatient admissions for your practice, the per member per month costs, readmission rates, and things like that. Also, you can see the trend, and you can see how you compare with other practices in the state, and how you trend over time to see when, for example, if you started in Q1 of 2019 and you see your ED utilization and inpatient was so high, but you had different PDSA and test of change that you had put in place, following up with patients, providing longitudinal care management to best manage their conditions, then you can appreciate the results when you see further down 3 quarters later, you see a downward trend in the patients. Okay, now it's not a one-for-one correlation, but again, just to at least give you some way to see the impact of the work that you're doing. And then this is one of the favorite things to me as well here. It's the pre-AH tool and the PQI-like report. Yes, you have a lot of algorithm risk stratification tools there. You have many of them. There's some of them already configured in your AMR. But the beautiful thing about the CRISP risk stratification tools they have is that they try to make it very provider friendly. They make it more targeted towards what you need to know to get the work done. So enough webinars are already recorded on this, and you have a link up there to learn more about it for those who haven't watched it just yet. But be aware that things to keep in mind is who in your practice should you designate to actually be the one to go in, look at this report, pull it down for the team, triage, sort it out. You have to keep that in mind because, this does require some dedication and time to focus, and you want to continue doing your day-to-day work, but make sure you have someone who's designated to reach in here and provide the right care team member the information they need. One thing I like about it that is an enhancement is that now you can download it as a spreadsheet, and you can look at the likelihood of avoidable hospital events and sort it out by your highest risk patients, so you can actually have the the other columns to check off if you contacted them, there was a follow-up, or the status of the patient, so that you're actually following up as needed. So one thing just to put in there about the PQI-like reports, the PQI is a preventive quality indicators. It's just pretty much if you want to do a drill down to understand, yes, I do have this patient who's high risk in the moment, and likely to have a hospital event, but what may be the driving factors? Because that can also help inform how you manage your disease-specific registries. Okay, so the last feature of the CRIS MDPC report I want you guys to pay attention to is the professional services. And this is actually a great tool because you can drill down to see which of your providers or physicians by specialists, place of service, and providers do your patients use the most or go to the most. And you can see your cardiologist, the cardiologist here, orthopedic orthopedists, neurologists, and all whatnot. So when you identify the specialists and that are the highest volume, that have the highest volume of your patients referred to them, you can establish a care collaborative. And in the next slide, we'll talk about that. So your care collaborative is an agreement between providers on patient care delivery. And this does not have to be a formal agreement, with lines signed on the bottom, but it should be an agreement that there will be a collaborative effort between both providers to support the patient. Here is an example of what a collaborative agreement looks like. And if you want to get started, identify the specialists and or providers that have the highest volume, highest cost, as we just showed you in the CRIS report. Reach out to them and see if you can secure time on their schedule. Draft something. As you can see, that's an example of things you want to talk about. How can we mutually agree on transition of care, access, and things like that? And then you meet and discuss and finalize that, okay, the primary care provider will do A and the specialty care will do B. And then you guys revisit this on a monthly, quarterly basis. The next topic here is the advanced care planning. This is key, especially during COVID-19. As primary care providers, we are the ones that have the strongest relationships with our patients, and it's good for us to discuss their end-of-life preferences. Again, these are billable visits, so please look at the links below to learn more about these. I know most of you are already doing this, and from a practice staff perspective, especially with a lead care manager, please make sure that all the patients who are receiving longitudinal care management have already done an ACP. Remind the provider, make sure they're scheduled to come in to complete one. So as a recap of the last phase of the patient's journey, we had a practical conversation about activities that usually occur outside of the patient's office or virtual visit, and these include episodic care management, follow-up to ED and hospital discharge, using data to continuously improve delivery, especially using your CRIS tools, alternative care visits like virtual visits, which a lot of us do now, using data to plan for care for your patient population, care collaboratives, as well as advanced care planning. So now I will hand this off to Ashley to present on social determinants and patient engagement. Ashley?
Good afternoon, everyone. Thanks for having me. So throughout this segment of the presentation, I will focus on the following: defining social determinants of health, helping you to understand what determinants may affect the patient's health, describing tools used to assess resource needs, and helping you to prepare your patients for their medical visit. So what are social determinants of health? The World Health Organization defines them as the conditions in which a person is born, lives, works, and ages. So what impacts do social determinants of health have on the health of a patient? Let's take a look at this guy over to the right. Notice the factors contributing to his genetic makeup. 40% of his life is impacted by socioeconomic factors. 10% is affected by his physical environment. 30% by health behaviors, and only 20% affected by healthcare. So what do these social determinants look like? It's your family's income. It's your ability to travel to and from, i.e. your transportation. And it's your access to fresh foods and clean drinking water. So how healthy is your community? If we look on this slide, I've listed here the annual rankings of how health is influenced by where we live, learn, work, and play. Notice that Anne Arundel County has a health outcome rate of 10 out of 24. This means out of the 24 counties listed in Maryland, Anne Arundel County placed 10th as it pertains to health factors, such as social and economic factors, clinical care, and a patient's physical environment. Tools such as these help us as community health workers to be able to raise awareness about factors influencing health, They help us to initiate community assessments and planning in areas of concern. And these tools also help us to revitalize existing community health improvement strategies. Now let's take a look at our test patient one more time. We met her earlier, and this is 71-year-old Miss Anexa. If we take a look again at Miss Anexa's social profile, she is a retired widow with no family living nearby. Note that Miss Anexa has recently been hospitalized and that this time she has no fresh food at home. Now, after discussing a few factors that could affect Miss Anexa's health, which social factor is of highest importance to address first? If you can please refer to the poll and give your answer, and we will share after we have everyone's answer collected.
All right, we have about 10 seconds before we'll close the poll.
Okay, awesome. Thank you, Angelica. So if we look at everyone's responses here, we see 3% said social interactions, 3% said transportation, 70% said food insecurities, and 23% said housing. So in regards to Ms. Anexa's social profile, we would say that her highest importance social factor right now would be her food insecurity. She has stable housing. She just does not have any family living nearby. So that definitely could be a concern of hers, but we must first address her food insecurity. And the reason being is just that this is a physiological need. If we take a look at the pyramid here at the bottom of our slide, this is Maslow's hierarchy of needs, which I know we've all seen plenty of times before. And we know that the physiological needs on the bottom of this pyramid take priority above everything higher to address first. So thank you all for your responses. Okay, so moving forward, as a reminder, MDPCP requirements state that practices should complete an assessment and conduct an inventory of resources as it pertains to social needs. The MDPCP requirement also states that practices should utilize the health-related social needs screening tool. So now that we know what social determinants are and how they can impact a patient's life, let's take a look at a workflow for addressing these social needs. A typical day in the life of a community health worker would start off by receiving a patient's referral. The CHW then would outreach the patient and conduct some baseline assessments to just get an idea of what this patient has going on in their life. Community resources are then shared with the patient based off of the assessments that were completed, and periodic check-in is typically scheduled with our patient. When all needs have been met, the case is then documented and closed out in the electronic health record. Of course, there are instances, however, when the patient can't be reached or all of the needs have not been addressed following this workflow. So in that case, sometimes this will result in what is referred to as a home visit. And we see at the bottom of our screen, home visits are conducted sometimes when a PCP or CM may request one, if the patient has been unable to reach, if the patient has safety issues, if there is a in-person assistance check needed to help our patients complete some assessments and some paperwork, just to name a few examples. So what goes into planning this home visit that the community health worker is going to conduct? And I just wanted to make a note that due to the current climate, COVID-19, some home visits right now are being transitioned over to what we're referring to as virtual visits, much like telemedicine. So we do still have to decide what goes into the planning of these types of visits. So here I've listed just a few steps before the community health worker would conduct this visit. They first want to establish what the visit is going to be for, then move forward to establish a protocol for the visit, i.e. some safe practices for staff and patients. We then move forward in establishing protocol for addressing the social needs that we will identify through our assessment. And we then want to move forward to establishing measures for reporting data in our electronic medical records. So if we take a look here over to the right, there is going to be a social determinants of health wheel that appears here. This wheel just highlights the categories of concern based off of the patient's responses to a social determinants of health assessment that may be conducted during a home visit. So this is one of the tools that the community health workers use in an electronic medical record that helps them to identify barriers to care. And as we can see on our screen, this person, just like Ms. Anexa, has a food insecurity present, and that would be a priority for us to address first. So moving forward, another responsibility of the community health worker is sometimes to prepare our patients for their upcoming office visits. So here I just listed some helpful tips that community health workers use to best prepare their patients for their doctor's visit. And again, just to note, due to the current climate with COVID-19, some office visits are being rescheduled or transitioned over to virtual visits as well. So I just listed some stats here over on the left-hand side of your screen, and I just wanted to make note that 74% of telemedicine users had their care concerns resolved during the first visit. So a lot of changes are happening right now due to the global pandemic, but we are seeing some good stats in regards to addressing our patients' concerns. So the next few slides are just going to be some handouts that will be available for you in the third handout that's attached here. And these handouts will just prepare our patients for upcoming doctor's visits that they may have. This is a document that a community health worker would walk a patient through and just helping them to outline all that is discussed during either an in-office visit or a virtual visit. Okay, and listed here are some examples of screening tools that we use to identify and address social barriers. So the first screening tool that's listed here is the CMS Health-Related Social Needs Tool. This is an assessment that is comprised of 14 questions ranging from family and community support to food and transportation access. The next screening tool that we have listed here is the American Academy of Family Physicians tool. This is an assessment that community health workers use that is comprised of 15 questions and aimed at 5 core health-related social needs. We then have listed here the Prepare Toolkit. The Prepare Toolkit consists of the Prepare Assessment, which includes 15 core questions and 5 supplemental questions. And the goal of this toolkit in particular is to provide users with resources that are best going to help them practice and apply lessons to guide the social determinant needs that are identified through this assessment. And that's just to name a few of the screening tools that are listed. So as a reminder, conducting an inventory of resources is also an MDPCP requirement. So here we have a list of resource libraries and directories that are available to not only our community health worker staff, but all clinical staff as well as patients that may want to access these libraries. Just to explain a few, United Way 211 is a free and confidential service that helps people across North America find local resources 24 hours a day, 7 days a week. They are always available. Aunt Bertha is an online resource library that connects our patients, hospitals, and community health staff with resources to better manage the patient's social needs that are identified. And then we have Maryland Access Point, which is the Aging and Disability Resource Center that's really aimed at providing some counseling to those seeking information, referrals, and program support for any long-term services. Okay, so we have discussed what social determinants are and how they're best addressed. And now we can focus on the individual that is addressing these issues. What is the role of the community health worker? Well, we know the role of the community health worker has shifted just recently since March 2020, of course, with the global pandemic that we are now facing. So here on the left-hand side, I have listed some of the characteristics, some of the responsibilities that go into the role of the community health worker. But I also will list off to our right some of the responsibilities that the community health workers have now had to adapt to and grow in addressing the global pandemic that we're facing right now. So just to name a few, instead of just increasing access to health services, CHWs are now acting as community level educators, organizers, and mobilizers. Instead of just communicating important public health concepts, CHWs are contributing to disease reporting systems for things such as contact tracing, like Dr. Haas mentioned earlier. And while CHWs are still focused on reducing the burden that's felt by healthcare, they are also completing medical tasks that are unrelated to the infectious disease outbreak. By doing so, they are educating on safe practices and even some symptoms of identifying COVID-19. So in addition, here are just a few examples of other ways that CHWs are supporting the community during COVID-19. One, through food and grocery delivery, also through appointment scheduling, PPE creation and delivery, and unemployment assistance. And here are just a list of resources available for health workers during COVID-19. I wanted you to place your focus on the third bullet here, listed Dia de la Mujer. This is recorded webinars that are available promoting self-care training for our community health worker staff. And this is very important, of course, now in the global pandemic with community health workers kind of being out on the front lines addressing some issues that our community is facing. Okay, so after discussing what goes into addressing social determinants of health, would you say your primary care practice has resources or services available to help patients address their social needs? Yes or no? And you can respond to the poll that is on your screens now.
About 10 more seconds before we close this poll.
Okay, awesome. Thank you everyone for responding. Thank you, Angelica. So it looks like 89% of you said that you do have resources and services available, and 11% said that you do not. So for those that said that you do not, of course, as everyone has mentioned previously, we just want to encourage you to reach out to your CTO to get with your coaches. There are many different associations right now that are available in posting opportunities for community health workers that are certified to get out in the field and work with, the community in these different offices. So if you do have a question, you can please feel free to ask me at the end of this session or get with your CTO. Thank you. Okay, so moving forward, as another reminder, MDPCP requirement also states that practices should convene patient-family advisory councils. And so as many of you already know, a patient-family advisory council is defined as a group of staff and volunteers. The volunteer patients and families typically collaborate with employees to provide guidance on how to improve the patient and family experience. So this is oftentimes referred to as the PFAC, and in order for the PFAC to be fully functional, the framework must consist of the following: establishing and maintaining a PFAC, ensuring that your patients are meaningfully involved in the design of care, communicating to your patients and their caregivers about the changes implemented by the practice, and regularly, reviewing the patient data with your PFAC and assessing changes. So just to recap, we have defined what social determinants of health are, and they are defined as conditions in which a person is born, lives, works, and grows. We define the requirements of the MDPCP program to include practices completing an assessment of social needs and conducting an inventory of resources, and utilizing health-related social needs screening tools. We've reviewed support and resources available for community health workers during COVID-19, and we have discussed what a patient family advisory council is and the requirements for the MDPCP program as they pertain to the PFAC and the framework necessary for the PFAC to function properly. Thank you so much for your time, and I will be available at the end for questions.
Thank you to all the presenters. They did an excellent job today with presenting the sessions that we have posted for you guys. So right now we want to run through some of the question and answers. There were a couple of questions that were sent through the questions and chat box. So we'll go ahead and begin that Q&A session. So for the first question that we have that was asked, this is directly asked to Dr. Okeke. So the question is, can you go over the workflows again, explaining the care team roles?
Yeah, thanks for the question. So let me provide some background, I guess, before we talk about the workflows again, especially for practices that are using or selected or opted to use CTOs. So there is a CTO practice arrangement that was signed between both parties. And in there, the initial work was done to identify for each of the different functions and indirectly tied to requirements, what would the CTO offer to support you? So I think that's where to start in order to identify at least what needs to be done and, you know, who can you have, you know, on your care team. What can the CTO offer you, and what can you, you know, get more of? So with your CMF funds, if you can hire more support resources, as well as add that to the resources that the CTO will provide, then that's where you start. So first of all, identifying the what needs to be done, identifying the resources that you have with a good dialogue with yourself and the CTO, or if you don't have a CTO, then you can determine based on the additional funds you got, you know, where are the gaps? And you may not get that right the first time, so it will take some iterations for you to get to where you want to be. So when you do that, then we now can do a deeper dive to look at the workflows, because now you have identified what needs to happen, you've identified the resources you have. So as you start working through what needs to be done, it's very clear to see what the gaps are. In a case whereby you start with making do with what you have, then you have to focus on what the handoffs are. So if, for example, you have determined that you would have one of the MAs in the practice to be the ones to focus, on looking at the outreach for patients who had a recent inpatient admission or inpatient discharge or ED visit, then at least that's dedicated to them. And just what you have to be mindful of is the volume, right? So this is going to vary by practice. So if that one person can handle the volume on a daily basis, then that's great. If it's too much, should you ask somebody else to support? And this particular MA that you're assigned to support with this, do they also have to run patients or prep patients, room patients? What does that look like? Do they do this first thing in the morning, last thing in the evening? So these are all the things to kind of consider as you begin to think through coming up with a workflow that works. For the lead care manager, I always would think of it this way. The name lead is there for a reason. They're leading something. So they are leading the charge for your practice for care management, which is, as you have seen in this presentation, it's kind of broader than just a one, track thinking. So they are supposed to be kind of overseeing the care management, care coordination for your practice, and they will be supported by the MA or any other support care manager or care coordinator in a way that makes the most sense, so that you can have the lead care manager focusing on the very high risk patients that need long-term care, but at the same time kind of helping with guiding, in some ways with other rising risk patients. Because what we don't want to happen is focus on the high risk patients and forget that some folks who are rising risk are ignored and end up becoming high risk. So where the support care managers and the MAs and stuff can also do a bit more with supporting your mid risk tier patients. That's helpful as the lead care manager is leading the charge in high risk patients, and then pulling in the CHW when needed, pulling in the MA when needed, and things like that. All this again should be articulated in a plan, in a care plan that should be found in your EMR. So I hope that kind of gave some insights into how to think about the workflow. Until you have those, different components put together, then it makes more sense. And please, if you have any follow-up questions, please reach out to the PMO office, and we'll take this back as well as another topic to kind of have maybe another 1-hour webinar just to discuss that. Thank you.
Great, thanks for that. All right, so the next question that we have here, which I think is a good one. What can you do when leadership is not as supportive with change?
Oh, I would have thrown that to you, Ashley, or or Angelica. That's a good question. We talked already about the change journey. We talked about change resistance. So when your leadership is not as supportive, I want you to, and I don't want to sound like I'm selling a soft skill here, but it's true. You want to rise above it to a place of empathy where you want to understand why. What stage of change is that person in leadership is, and see how you can come up with ways to make your case, if that makes any sense. So I think one thing that helps all along, at least from my experience, throughout my career journey, is if I had something that I felt could be done better, and I had superiors or my boss who I thought I would want to pay more attention to what I was saying, I tried to see how I could put the numbers together so you can work through with your teammates and say, I've been observing, patients waiting in the waiting room for X amount of minutes, and I know if only the front desk staff and myself can do some things differently, that would reduce wait time. So just having some more tangible examples to make the case for why you think you expect them to be more engaged can be very, very powerful and helpful. Now you can see you have more than enough, performance reviews with all the crisp dashboards and things that you can collect on the side. So again, see how you can discuss as a team with another care team member as well to articulate what the benefits would be had you had the leadership support, and hopefully that would help.
Great, thank you for that answer. All right, so next question we have is specifically for Ashley. So the concept of CHW is new to me, and can you share more about the process involved to establish these services?
Sure, absolutely. So the community health worker role in and of itself, of course, is a group of really frontline public health workers. These individuals have been trusted by members of their community. They've built relationships. They've a lot of times served as a liaison, a link really in between healthcare and social services in the community. So just to kind of put a definition on what the community health worker is, I know I didn't really focus on defining the community health worker. I just wanted to kind of put emphasis on that. And then the process for getting a community health worker on staff, of course, it's going to be different for every practice. But with the community health worker workflow that was shared earlier in the presentation, we see that the entire process starts off typically by the community health worker staff getting a referral for a member that is a patient that is in need. So if at any point there is a patient that needs to have some barriers to care addressed, maybe just be assessed for safety concerns within their home and just the ability to get to and from, that is the perfect time to get a community health worker on the care team, get the community health worker in there really working face-to-face, hand in hand with the patient to really meet those social needs that are identified from a non-clinical standpoint. And that's kind of just how the process starts. Of course, the workflow, like I said, is going to be different for every program, but the process typically starts with identifying a patient that has some social barriers identified or that need to be assessed by the community health worker. So thank you for your question.
Great. Thank you, Ashley. Excellent answer. Okay. So this next question, I think it's a good one as well. So with having social distancing in mind and challenges for video connectivity, some patients, they just can't manage it. Is there a presenter today that has actually conducted a virtual PFAC? And if so, can you please describe the virtual coordination process and describe the virtual PFAC end results?
I can speak to how you would approach that. Not that I've done one directly, but I've done so many other things that I had to reach out to participants and see how we could do it in a virtual way. So for those who are new to the program, the first step, I believe, if you remember what Ashley walked through, was to identify which of your beneficiaries, will be actively interested in joining the PFAC, meaning that they're able to speak up and share feedback and all that stuff. And most times the primary care provider is able to tell you which of their patients will share their opinion. So I think that's a dialogue that can happen internally, just to identify, say, 2-3 people who can speak up and share what they think, and caregivers as well. And then once you identify them, it's easy to go through the same steps that you normally would have, which is, share with them what the PFAC is about, share with them, how you're putting together an agenda, the different, I guess, policies that will guide the team when they come together, make sure they understand that this is a shared decision-making process that you guys want to initiate. And once you do that, you can, use telephonic means to, reach out, call, and engage them. It will take a couple of calls to kind of get that all established. And then you guys would choose a day that you would actually have the PFAC meeting. And if you have any documents to send by email, no PHI, just like a simple agenda. And then they know that, okay, this is what we're going to do when we have the conversation. And then people use a lot of alternative virtual visit options besides your EMR virtual video conference capability, so Zoom or Teams. With the issue about Zoom, people are kind of skeptical about that, so I'll prefer you use Teams. Doxime is another one that's popular. So how can you have that same virtual visit with 5 people or so who would be on the team and still conduct the PFAC as you would had they be in person? So I think the biggest thing is the pre-work before the fact, and that starts with, you already know who is on the care team who would be a good member of the PFAC. You can discuss with the care team, the primary care provider who would be actively engaged in such conversations, identify the key things, especially MDPCP and the changes that you intend to implement. Should be on the agenda item. Tell them what you're thinking about doing. If you want to enhance communication through the patient portal, whatever the case may be, give them a chance to give you feedback. And then after that, the next meeting should be a follow-up as to how you implemented their feedback, so that they feel that, yes, because we gave you this feedback, you actually did it something one way or the other. Another one with COVID-19 pandemic, you have more than enough resources that have been sent your way in terms of preparing the waiting area, how you want to schedule patients coming in and out. So most practices are doing this, without remembering that they could actually have that as a topic for discussion with your patients so that you get feedback from them as everybody's trying to be safe and practice, good physical distancing, I want to say, instead of social distancing. So think about that as well, because this will be a good thing to hear feedback about how patients feel about the changes that you will make now and continue to make in your care transformation journey. I hope that answered your question or gave you at least some insights.
Great, thank you. And these are all great questions that everybody is having. So thank you for the questions. In the interest of time, let's go ahead and cover off on one more question, because there are a couple things that I wanted to go over before I turn it over to Dr. Okeke for the closing remarks. So last question, with the warm handoff, how practical is it to implement in a small practice?
Okay, I'll take that one too. So with a warm handoff, what you saw in the video, yes, it was a video, and sometimes, it looks as though it's something that is a make-believe or a wishful thinking, but it depends on what your practice is doing, and it's different across the board. So there are practices that already do the warm handoff that way, but as you can see, what it would entail is that you do have a more dedicated MA supporting the primary care provider, and that way, when they're rooming the patient, there's all this information that's gathered about allergies, medication review, presenting complaints, and ROS. So while all that is going on, and then the physician is ready to meet with a patient, typically what I see more often done is that the MA leaves and the physician comes in and has to log into the EMR, whatever. But think about another option where there could be a warm handoff. So the MA can still continue on being in the room with the physician, and you can see that dialogue going back and forth, pretty much summarizing what it is using the SBAR methodology to share what the situation is, the background awareness, and things like that to the physician about that particular patient in that moment. And then he can, or she can then move on with doing the physical examinations, and then, um, on determining the best disposition and a treatment regimen for the patient. So I would, say to you that it is practical. There are practices that do it this way. If you need more kind of hands-on learning, we can reach out to those practices to say, do you want to share more about how you do what you do, or do you want to, have more tips or tricks that you can share with others. Connect is a very good hub for, people sharing their thoughts and things like that. So that's what I would say, that it is practical, it is feasible, but think about it as you go through your change journey, because it will take some modification to your staffing model to be able to do that.
Great, thanks. So I know there were a couple of other questions that were asked in the question chat box. So I'm sorry we couldn't get to those. We'll be sure to circle back and provide an answer to that in a FAQ document or follow-up email, So thank you so much for attending the webinar. Only a couple more minutes before we let you go so that you can enjoy this beautiful day. So hopefully you did find the training session and the topics that we shared helpful. Before I turn it over to Dr. Okeke for the closing remarks, a couple things I wanted to provide a reminder on. So first, I want to apologize to those that might have been having issues with downloading the handout document. So again, everyone will receive a follow-up email, and it will include a few items. We'll make sure to include a copy of all of the materials, and make sure that the links to the videos that were shared in today's training, you will be able to access that through the PDF document. Those links will take you directly to the videos that were shared. Also, for the follow-up email, We will also be including a link to a post survey. Please take some time to fill that out. We really want to know if the training was very helpful to you. In addition, we want to know what other topics you might want to see in the future. Last thing, look out for the instructions and the link to apply for the CME credits. So that will be provided to you in a follow-up email as well. So those are all the things that I wanted to remind everybody about. Again, I appreciate that you guys stuck with us, and hopefully this training was helpful. So I'll turn it over to Dr. Okeke for the additional closing remarks.
Okay, well, thank you, Angelica. So everyone, you cannot be thanked enough for the work you do on a daily basis. I know we are all stressed, we all work hard, but where you have to wake up every day, not just think about your own self and your family, you have to think about your patients and their life, and their welfare and how they're faring in this time. It's a lot. So please hear us when we say that we appreciate you and we're so happy that you make the time to come here and learn how you could do more for your patients, especially through the MDPCP program. So as Angelica said, we will continue our work through the PMO for MDPCP to support the best way we can. And if you have any questions, please know you have resources, more than enough resources to support you. Please reach out to your state practice coaches, for those who have CTO, your CTOs as well, and you should get an answer, right? Again, leverage the Connect as pretty much a peer-to-peer collaborative that you guys can use to share different initiatives and ideas that you have as we go along. So thank you so much for your time, and I hope that we can see you guys sometime soon. Thank you.